is an 87-year-old lady who has severe hypertension, and she's been coming for shortness of breath for the last 5-6 months. Her mean gradient was coming to around 20-26. We've been following her for 6-7 months, and she's getting more symptomatic. She had stents placed about 6 months ago, and she's still continuing to symptomatic. But each time we calculate the valve rate, it comes to around 0.9. So, Greg, do you agree this is a low flow, low pressure AS? Okay. And Andrew's going to show us some images.
Perfect. So this is a long axis view of the aortic valve. You can see pretty stenotic valve. You can definitely see turbulent flow through the speckling of the color flow Doppler there. Couple different images just for completeness. You get another view of the long axis view. Looking at it in the short axis, and then also just for completeness again, looking at the pulmonic and the tricuspid valves, both of which don't really show too much. Looking into the transgastric view, you can see that she has a very thick heart, but overall is contracting pretty well. Now in the deep transgastric, getting a max gradient of 30 and a mean gradient of 16, pretty consistent with pre-op. And then just in order to complete the calculations, trying to get the diameter of the LVOT, and then the calculations all done by the echo machine gives us the aortic valve area of 0.86, which I believe pre-op was about 1. So both consistent with severe aortic stenosis.
So before we start, we actually did pressure. Do you agree with that? This is stenotic valve, right? It is a low pressure gradient. So because there was some concerns, the mean gradient was low. So what we've done is we've actually got access in the left femoral artery for the pigtail, left femoral vein for the pacing wire. We've got a right axis, and we put in a single double perclose and a 14 French sheath. We plan to do a sentinel device, but what happened is there was a problem with the carotid was anomalous, so we cannot do a sentinel. Actually, I wanted to show we usually do sentinel in all patients, but this one we cannot do because it's anomalous. A gradient, so how much did you get by mean gradient?
29.
So they got a mean gradient 29, which is consistent with our echo report. So we are actually going ahead, so show the fluoro echo, and we're going with a safari wire. We tend to use a lot of double curve Lundquist, but for this valve, we'd like to use a safari wire, a small one. We're using extra small because the cavity is very small. So I'm just creating the wire loop, and then Greg's going to exchange the wire out. You know, Greg was responsible for some of the very important clinical trials, and it's really nice that Greg is here with us doing this case. And that's the reason why I actually want to show this case. He's going into VT because of the wire. I just have to pull the wire back a little bit. Okay, I think we're stable now. His pressure dropped a little bit. Can we bring the pressure up a little bit?
Coming up.
It's coming up. So they prepped a wire. We decided based on this, it was a borderline between a 23 and a 26. The sinuses are big, and so we've decided to use a 25 valve, and we're going to use the cusp overlap technique of doing it. So let's just take the arrhythmias out. So we were a part of the clinical trial, and we've just recently commercially approved using it. And I thought it would be a nice case to discuss because this is something which our audience would like to see. It's a different valve. It's a different self-expanding valve. It has definitely different characteristics. You can see the small curved safari, extra small safari is really nicely, safely placed in the apex. You can pull the wire back a little bit, Greg. And this went in very nicely. Okay.
180 or 180?
180 is fine for me.
So we're having patient 180.
So it is good to actually do the balloon dilatation in cusp overlap to make sure that you're not too deep. And so we're in this position, ready to go. So pacing ready.
Patient ready.
And pacing on.
Patient on, 180.
And then you have to do a fluorostor. Yeah, go. And deflate. And stop pacing. So there's not much of a waste.
Low calcium valve.
Yeah. So we have. I think that's another reason why using a 25 is the correct choice.
Fluoro, please.
But as this thing's nicely pointed out, that the LVOT is smaller, which means we have to be a little bit careful about this one, right?
Fluoro.
Yep. So we're going to do a very slow deployment. We're going to focus. This is our plan of action. The nice thing about here is I know you don't have to pace, but we will pace at 1:30 or when the valve is opening up. Is that okay? But I'll talk as I'm
So
going.
it's a good thing to bring up. It's because the leaflets are intraannular. You have flow through the valve very early, and so it doesn't mandate that you have to pace during deployment. But I feel, especially with low calcium valve or AI, you can tend to have a little movement, and intermediate pacing may stabilize the deployment.
Okay. It's going very smooth, without any resistance at all, and the valve is moving beautifully up. Okay, so we just go around the arch. We don't. Okay, it's good. And this is the beauty of this valve. It's very flexible, and it goes down. And you see how calcified the arch is. And these are coefficients where you can actually cause a lot of strokes and things like that. You want to pull the wire a little bit, Greg? Okay, so test the contrast, please, Colleen. Test. Come closer to us. Test. Yeah. Okay, that's good. I will actually pull the pigtail right down in the pigtail. Test.
One more test.
Test. Good. So this is a very nice position of the pigtail. So we want to be, our goal should be to be 3-4 millimeters
Correct.
below the pigtail, correct? So Andrea's talking to me, and she's telling me to put the constrained end of the valve just at the bottom of the pigtail, which is correct. And we'll test it. Actually, what I like to do is I would actually like to take this pigtail back out and then put it around the vessel. So it doesn't. See that? That's much better. So that's
One more test just to confirm.
okay, so let's collimate. There's a lot of lung field. Let's collimate again on the sides. Let's center this in the lower part. Let's magnify. And then collimate. Good, sideways.
Start a little deeper.
Yeah. Okay, I'm going to start a little bit more deeper. So I'm going to go a little bit more down right from here. And we start from there.
So this part you can go fast on. So we're just bringing that delivery catheter up to meet it with the constrained edge of the valve.
Yes. So as you see that the sheath is coming back.
Yeah, that's perfect.
And you can start coming back a little.
Go ahead and start pacing.
No, I would like to come out a little bit more. Is that okay?
No, that's fine.
We could come out a little bit more.
So we flower.
Yeah, till we flower. And I would like to test over here because you want to be a few millimeters below.
And go ahead and give it a little bit of forward pressure.
Yeah. Okay, I just stick with Cine. One a little bit lower down. Looks good, eh?
Okay, no, that looks perfect. And go
Okay.
ahead and pull your wire back
Now,
a little bit symmetrical.
so I would actually at this point start pacing at 140.
Pacing at 140.
Yes, wait, great.
Pacing at 140.
Okay, test please. Test please. And the depth is really nice. Just a 3-4 millimeters, and it's going very nicely. Test a little bit. Okay, I'm getting a little forward.
Go ahead and pull your wire back just a little bit more.
There's no way you want me to start coming down.
Not yet. Test a little more. And you see the valve is starting to function. That's why the valve is so stable. As Greg was saying, it's fully functioning.
Can I hit the brake?
Yep.
Let's stop there.
Stop.
Okay.
Come down on your pacing.
Start. And so we gradually bring the pacing down. We don't suddenly stop. And we'll take one Cine here. I like that position, right?
Swing
Now let's do LAO. Let's go.
No cranial, no caudal.
Okay. No cranial, no caudal.
And we're going to take the parallax out by just going LAO.
Okay. I think that's good, right?
We have a lot of parallax there.
A little bit more.
It's still bottled.
Yeah, you need to go.
Are you still pacing?
I'm not at 100.
Now stop.
Come down.
Come down now. Okay, good. I like that, right? No?
It's pretty close.
It's pretty close. Yep.
Okay, good.
Okay, so we're gonna take another big picture.
So, yep, let's look at the left cusp in this picture, make sure that we're
Yeah.
touching.
Good
So
coverage.
you see, this is what Andrea is saying. She wanted to see in this LA view how the valve is touching the left coronary cusp, correct?
Exactly.
And you can see it's also 3-4 millimeters down. And I think we can deploy now, right? Okay. Now advance the wire. So you can see now I'm slowly, no, he's going to pull the nose cone back. I'm going to pull the nose cone in, and now he's going to push the wire in. Push the wire a little bit more carefully in. Good. And see, this is a very critical point that we should not catch the valve as we're pulling out, which we didn't. And let's demagnify and go to 0. And let's go to AP. And we'll start looking at echo now. So you want to come back, Greg? And now he's going to recapture the valve.
So go ahead and use the blue tabs.
So you can show how can you show that magnify on his hands? And as you go in, and you just pull it slowly, beautiful, and the wire, be careful of the wire.
Yeah, got it.
Okay, and then,
Stick your hand in and walk her out.
okay, good.
That's a new technique I haven't thought of.
Do
Okay.
we,
Yeah, we're going to put the sheath in. Give me the sheath.
Ready?
Yep,
You have wire?
yep. So do you want to do some images now for us?
Sure.
We had no hard block. It's a very smooth deployment, right? It's almost like a sapien valve.
Easier.
but,
Andrea's very insulted.
well, because you get better. I mean, it's,
I'm being
but- I was
sarcastic.
going to say it's better. It's better.
You don't notice I will go car.
No, I don't.
Some LVOT.
All right, let's measure the gradient for that. One minute, let me just flush this.
You think we're still in the LVOT REO?
So the mean is 7. No, it's 2. So the mean gradient is 7. I think it's okay. Let's
Yeah.
peek. All right, ready for pullback? What did you get, by the way?
Andy?
And you see the peak gradient was higher in the green.
As well.
This is the pressure tracing. So you can see actually it's almost 0. You can see,
say it's a lot lower than
yeah, actually it's less than that. And what are you getting gradient?
I got a -7.
So you got a mean of 7. But I think it's really low. And look at the T. Now, can you show echo large? Can you show his echo images, which really look nice? Pedro, can you show echo, please, for them? Can you show echo? That's good. That's very good. Now, let's go a couple of images. You can see the TE. The valve has absolutely no leakage at all. It's in the right, it's a very good position. The gradient is clearly less than 10. We think it's 5 actually over here based on this. Can you just show us the short axis and the pericardial, and then we are done? And then we're going to focus on the closure of the groin and things like that, which we like to do live.
Short axis.
Yeah, and you can see a very nice short axis view showing that there's no contrast and there's no perivalvular leak. Now, before you stay on fluoro, I just do one injection. What's your creatinine, by the way? Under 1, okay. So, Greg, do you mind if we just do one angiogram? We like to do one angiogram. It's not always necessary if we get such good echo images, but I just want to do it for teaching purposes. We like to do one angiogram. No, we're going to do with a. Oh, do you have the power injector? Yeah.
It's loaded, we just need to hook up.
Yeah, you already hook up. That's where is it?
Do that. Okay, ready for hookup.
Where is it? Oh. You like it? Nice, sir?
I like it.
Yeah, Andrea, you're like a star now. We're lucky to have Andrea over here. John, are you okay? For a change. So we just have one more picture to take, and I think we can pull the pacing wire out, right? Right? So we're going to pull the pacing wire out. We like the images taken already by echo. There was no effusion, right?
There was not.
The blood pressure is stable. Um, and the beauty about this valve is that it's got very large cells. And it was very stable deployment. Even though the calcium was low, it didn't move at all. Inject, please. Oh, no AI at all. So that was zero AI. That was a good position. So now we're going to take the sheet out. So we're going to see the pacing wise out. We actually want to go through the steps of how we take care of the groin. We take this very seriously, especially older people with calcified vessels. So the first thing we're going to do is we're going to exchange this wire and put a mammary there. Okay, good. And you can see by fluoro, you can see how calcified the vessel. Now, I want us to focus a lot on the groin itself, the way we're going to take care of the sheath. You can see, so first get the mammary catheter. We advance a 5 French mammary catheter over the left groin because we are actually going to go up and over. To do an angiogram. I mean, look at this vessel, how calcified it is by fluoroscopy. Good. Okay, good. I mean, you can also see the entire tortuous vessel, how it is. You're going to get half the dose of protamine? How much does she weigh? You just give the half the dose, I think.
Half dose.
Good. All right, so now let's get the second wire. Can I get the second wire? So now we're putting a second wire up the groin sheath, and then we're going to use the dilator. We always pull the sheath with the dilator because it helps sometimes the lip of the leaf sheath doesn't get caught in the tissue. And these small little things are very important to prevent vascular complications, especially in such elderly patients. She's 87 years old, highly calcified vessels, tortuous arteries. These can actually tear and rupture very fast. I'm really happy that we chose a 25 over a 23 in this case, right?
I mentioned also that we go to sleep just with a central IV, and we have our arterial line slaved on the right and the left groin to a 7 French.
Right, and the venous line.
The venous line to the central venous. So we finish the case. She should just have a central IV.
Yes. So let's go with this. So can you get my lights on this and put the table out? Okay. So now we have 2 percloses in, and often we reinforce with an angioseal. We reverse the heparin only a little bit. Half the dose, we give 6,000, but we'll only 20 of protamine. Yes, please. Okay, good. Okay, so now let's get to RAO view. And let's put it in perspective. Let's open up. Okay, let's open it up. Okay, how do I put this? Sorry, I want to show the femur. Yeah, yeah. No, the other way. Okay, good. That's it. Okay, that's great. Test. Okay, let's do a angio. No, now. Well, looks beautiful. So, no flow, no extraposition of contrast, no stenosis, and just a little ooze. And now we're going to close the left groin with a 6 French angioseal 2. And our blood pressure is like 170 now. No, do you need one?
One
Okay.
more engine too? Yeah.
Uh,
Do you want me to?
yeah, you can shoot it. You want to shoot it? No?
Yeah, I'll shoot it. Let me say goodbye.
Mm.
Is it gonna?
Yep,
All right, perfect.
yep, it's under verification.
Perfect.
So I think it's, you can now put it next time you see it. And I actually, while I end the case, I want to summarize. This was an 87-year-old lady with low flow AS, went a successful TAVR with a 25 millimeter portico valve. Actually, that's the Navitor valve, which is going to leak. We have Andrew Cannon who did anesthesia and echo. And we have a whole team. Steve, thank you for being here. We always have perfusionists around. We all have the staff. And John, who usually doesn't do much of work, is coming in to help out. John, thanks.
Thank you, sir. It's wonderful